Hello, I'm Dr. John Kruse, and welcome to today's question and answer session. This is for any questions you might have on ADHD, the videos I just released, mental health topics in general, and the usual disclaimer that the information presented here is for informational processes only. It's not making prescriptions or recommendations for anybody. If you can hopefully use this information and bring it back to your doctor or treatment team if there are specific questions. And also a shout out to the subreddit that I have under Dr. John Kruse, if that's a better way to ask questions or have a group give their responses or ideas or thoughts on them, we can try using that. And without further ado, the two videos that I released, one was an old one re-released and one was a new one. The new one was on global warming and ADHD. So there is incontrovertible evidence that temperatures on this planet are increasing. And although lots of the attention in terms of disasters and loss of life is focused on huge storms, wildfires, individual weather events, clearly already more deaths are happening from extremes of temperature, either way too hot or way too low. And there will be many more days that many more humans on this earth are subjected to excessive temperatures. And when temperatures get above a certain level, and that level is a lower number than we used to think, so it's substantially below 30 degrees centigrade, that without fans or air conditioning or other cooling, a human in such an environment, even doing minimal work, not strenuous work, will start producing more heat than they can dissipate. And that can lead to a number of problems, and including one is exacerbation of ADHD symptoms. So troubles with prefrontal cortex executive functions, and the unfortunate sort of, I'm into feedback loops, as people who've listened to these know, that means higher temperatures are leading to less ability to plan and execute, to pay attention, to focus, and those are exactly the skills we need to produce a concerted effort to reduce global warming in this world. So that was one video that was the new one that was released. The second one that was sound edited and re-released was on object permanence in ADHD. So there's I would say a misleading meme or notion going on out there that people with ADHD have a problem with object permanence. So if something isn't right in front of them, they forget about it, they can't recall it, they're not aware of it. It's out of sight, out of mind. And that's actually not what object permanence means. Object permanence is a term coined by Jean Piaget more than 150 years ago. And it's tied to the notion in development of very young infants that when an object is out of their sight, they act like it doesn't exist anymore. Not that they can't recall it, not that it's not in their conscious memory, but that it really does not exist. And the development of the idea that something out of sight is really still existing is an important developmental stage. So yes, again, out of sight, out of mind is common among those with ADHD. I'm forgetting there's a few other phrases that people use to discuss that phenomena, but that doesn't mean that people with ADHD really think the object is no longer in existence. So again, if there's questions on those topics or on any topics, those are just sort of starting points for the conversation. And I see Max has a question already today. So Max is saying, hi, hello. Since temperature has an impact on ADHD symptoms, is having a fever more debilitating for someone with ADHD? How about sports? Would one have less endurance because of elevated body temperature? So I don't know that any of those questions have been empirically studied. So again, what's been studied is just cognitive functioning in individuals without ADHD. A number of different executive functions start being impaired so that someone with a non-ADHD brain starts looking more like someone with ADHD as brain temperature goes up. A reminder that we are endotherms. We regulate our own body temperature. So humans can exist in a pretty broad range of external temperatures and use both internal mechanisms physiologically and behavioral approaches like fanning themselves or turning on the air conditioning to cool their internal temperature so it doesn't rise too high. So we regulate internal temperature pretty within a narrow band by a range. So as one of the writers, commenters on the video mentioned, that many people with ADHD seem to be more affected by a range of extreme stressors than the general population. So whether it's extreme hot or extreme cold or extreme humidity or something else, this seems to cause more physiologic stress, more distraction, more disruption to individuals with ADHD. And again, in sports, usually, so what are the effects of fevers? So again, I don't know any specific evidence of people with ADHD, for example, being more susceptible to the effects of fevers. Usually, if a fever is within a small enough elevation of temperature for a short enough amount of time, there don't seem to be long-term sequelae for most people's brains. Fever does increase the risk for seizures, particularly if it's high enough. I don't know if we have doing things to reduce the amount of internal body temperature increase you would expect if you didn't take compensatory mechanisms are in play. So again, during most normal sports, even if you're feeling hotter, your body core temperature is not rising that much. Again, it's rising a little bit, but still within the normal range. Whether, again, people with ADHD are more impacted by that than others, I haven't seen good evidence for. I do have a talk on exercise in ADHD, and there's pretty compelling evidence. It's not extensive, but a lot of studies done a lot of different ways showing ADHD does appear to have robust benefits for, and exercise has benefits for the brains of people who have ADHD. So that's all I have to say for that one. Dennis is asking, hello, Dennis, a question about pre-pulse inhibition, and if I have an easily understood way to explain what's going on. So I don't have a sophisticated way. So the phenomena of pre-pulse inhibition is when a weak stimulus or a weak signal to a nerve reduces a subsequent response to a stronger stimulus. So part of my hand-waving explanation is we often focus in network figures of neural pathways as sort of one neuron connecting to one other neuron, or maybe two have an input, and then that triggers something else further down the line. And the thing to remember is each of the nerves in our brain has hundreds, if not usually thousands of inputs from other cells. Many of these may be acting in parallel along parallel circuits, but many of them are also additional pathways feeding in. And whether a nerve cell fires or not, it's doing a mathematical equation or a mathochemical ion influx equation, and it's the additive impact or subtractive impact of all the input into the neuron that decides whether or not it will fire in response to the cumulative total of input to the cell. And an action potential is a sort of yes or no thing, but the strength of ion fluxes is going to be dependent on how many ions are in each side of the membrane to begin with. And Again, priming by getting a weak signal ahead of time may affect membrane permeability, may affect the presence of where ions are, so that a subsequent big enough stimuli to trigger things may have a smaller output. So I hope that's sort of a hand. I don't know if that's enough detail or enough clarity or either, or if there's an electrophysiologist, maybe I've even mangled the concept. So I'm going to stop there. So Antaretsa Magome, is adrenal fatigue real? And can Vyvanse make it worse, which can be used to help adrenal fatigue? So there really are adrenal glands. The adrenal glands really produce cortisol and other important hormones that signal energy levels and activation and trigger repair and inflammation in different parts of the body. Adrenal glands can be stressed out enough, or if you're receiving external steroids, because there's certain conditions where you have massive inflammation or other situations where steroids are still the most effective treatment, but being on external steroids for too long suppresses your own body's ability to manufacture those steroids. So if the external steroids get stopped too quickly, you can be in a state of adrenal insufficiency for a while. So those are all true and observable phenomena. My take is that the sort of the non-medical general term adrenal fatigue is widely under or overemployed to suggest that we know why someone is feeling tired, fatigued, or unable to do things. It's plausible that this is playing a role for some individuals. Again, the adrenal glands are under a feedback system. So under normal conditions, if you're, if it's too active, it has mechanisms to shut itself down after a while if it's too underactive. So it regulates itself. So in addition to cortisol, or part of what cortisol, part of the adrenal response is to cause a sympathetic nervous system response, which includes release of norepinephrine. Norepinephrine reuptake is an important part of how Vyvanse is working and forcing more norepinephrine to be released when it is released from cells. So there certainly can be interactions. So could Vyvanse worsen adrenal fatigue? Could it be used to treat adrenal fatigue? It can be certainly used helpful in fatigue, again, whether it's adrenal fatigue or not. And again, it's that enough stimulation makes anyone feel activated. I think I've said what I have to say there. Maybe a slightly different angle or question on it may lead me to try to say something more. Leanne Quitafa says, how long have you studied ADHD and ADD, ADHD? So I'm happy to go into this one at length, and I've talked about some of this before. So I have a PhD in basic brain research. It was actually on circadian rhythms and looking at the effects of antidepressants on the suprachiasmatic nucleus. I then went through, in addition to medical school, after medical school and PhD land, I went through a psychiatry residency program at the University of California, San Francisco, which is considered one of the top medical centers in the country. It's been number 2 or 3 in terms of NIH research dollars for most of the last 30 years. And in 4 years of the psychiatry program there, which was a good program, there was not a single mention of the possibility, and I'm a good listener and had a pretty good memory, at least back then, not a single mention in 4 years that an adult could have ADHD. Shortly after I finished the residency training program, I was referred a patient who I'll call Frank because he always was because of his ADHD. So he was in his 40s at that time. He had just spent 7 years with a widely respected psychoanalytically oriented psychiatrist. And the psychiatrist said, this is a bright guy. He's, cooperates. He shows up, he listens, he has insightful things to say. And in 7 years, I have not made a single dent in any of his behavioral problems. We've treated aspects of depression and substance abuse and not being able to function in life. So Frank was on disability at this time. He had worked at more than 100 different jobs before getting on disability because he could not hold any job for more than 6 weeks, including, and I don't want to single this out as the task requiring the least amount of ability, but including cashier at a grocery store. Because even at that job, again, not that it should be denigrated at all, but most people of above average intelligence could perform as a cashier. But Frank, when he was people in line, he would start commenting on, oh, you have beautiful earrings, or oh, I like the way you did your hair. And he was engaging. He would get in conversations with people, or oh, cool cowboy boots you're wearing. So his lines invariably were longer than all the other checkout lines. And then because of his ADHD and his inattentiveness, when people paid him, and those were the days that cash was still king, he'd say, did you just give me a $5 or was I giving that back to you in change? And often enough, people would lie and cheat him out of money. So at the end of the day, his till is always short, his lines are always longer. Why would anyone keep him on as a individual? So getting back, so this is Frank in 1994. So previous psychiatrist referred him to the UCSF psychiatric department for 3 days of in-depth neuropsych testing. Could this guy have ADHD or not? And they did 3 days of testing, and they said, if this was an 8-year-old boy, we'd have absolutely no question he has ADHD. He's constantly talking. He's not psychotic or deranged. He just can't control his impulses. He's walking around the lab in between sessions where we're trying to test him. He's impulsive. He's inattentive. He has problems with distractibility. But since ADHD doesn't exist in adults, we don't know what the hell he has. Here, you take him, brand new psychiatry, recent graduate of your residency program, and you see what you can do with him. And again, there was some depression in the picture. There was intermittent substance abuse, particularly heroin use. But it was very clear after ongoing evaluation and discussions that Frank's major prevailing problem rendering him so dysfunctional, and was ADHD, and he to this day has one of the most severe cases I've ever seen. So it led me, and right about that time, there were a few papers being published that everyone with ADHD doesn't outgrow ADHD. Adults can really have it. So that was in 1994, and it was largely self-education, reading the papers that were coming out, studying what was known about childhood ADHD. ADHD is still a field where the majority of our medication interventions, where the majority of our behavioral interventions are tested or explored or most developed in kids, and then almost everything that's been shown to work in kids has been shown to work in adults with ADHD. So that's a long-winded answer, but that's how I got involved in ADHD. I'd say the other two things I think that were good or useful is that working independently. So I did have initially some clinical appointments, but I did not go into academic psychiatry. And that meant that I could be freer to explore what was interesting to me. It was also meant I could be freer to talk about what I wanted to talk about. And I was less wedded to certain types of groupthink. Or the other thing is because I have training in PhD and research approaches, and I think I also listen pretty closely and well to patients, there are some things that became dogma in the ADHD field that all the experts were touting that my own individual experience just with patients didn't agree with. So one was, for decades, the claim, and this was compounded by Strattera, and I talked about it with Strattera, was that stimulants work immediately for ADHD because they make more dopamine and norepinephrine available, and immediately means minutes to hours. And all of our other approaches, like tricyclics that were being used, Wellbutrin, Cymbalta, then atomoxetine, Strattera, all these others are more like antidepressants, and we know antidepressants work slowly, and therefore all these drugs should work slowly on the order of many, many days to several weeks to alleviate ADHD symptoms. What I observed with people who tried Cymbalta, who tried Wellbutrin, was that they got results that day in terms of helping ADHD symptoms. And in terms of basic science expectations, these are drugs that make norepinephrine, or in case of Wellbutrin, norepinephrine and dopamine, immediately available within minutes to hours. So both on a neuroscience perspective and a individual patient perspective, you would think that some of these drugs should work as rapidly as stimulants do. And yet the dogma, and I went to dozens and dozens of lectures by different people who all quoted that same comment. So I think my background helped me to learn what was there and to take with a grain of salt things that others were proclaiming and didn't seem to be valid or true. So that might have over-answered the question. So 30 plus years now for studying ADHD. So Max is sharing a question from the Reddit page where Pristine asked, and potentially whether it's an interaction with ADHD or autism, on the insistence on sameness and rigidity and rigid behaviors, needing things to be a certain way. Are there any medications that are effective for these behaviors? So what my answer there is going to be clinically more than research-wise. So many individuals with ADHD do need things to be a certain way. I can remember going on a trip to the zoo with a 7-year-old, intelligent 7-year-old who had ADHD, who wanted to see the lions before we went to see the monkeys in this group of individuals, and had a complete and utter meltdown and just could not, and the whole day was ruined for them and pretty much everyone else because things were out of sequence in her mind, and her parents were unable to present that monkeys then lions wasn't that different than lions and monkeys, and it was just a few minutes difference. And anyway, so rigid thinking can certainly happen as a part of ADHD, or just having expectations that, you know, I left my gloves on the mantelpiece, I can't find them, and yet they're sitting right there on the desk, but because you have a different mindset or template for them, they're invisible. This is sort of related to the object permanence issue. So I'm not aware of tests or medication tests that have specifically looked at whether that element of ADHD is responsive and or whether it's an ADHD autism trait, whether it resolves specifically with medication. What I can say, I've certainly had individuals report on both methylphenidate and amphetamine-based stimulant responses that they were more flexible, more able to respond to what was in their environment and not needing or demanding it to be a certain way. So I've certainly had patients report increased flexibility from our conventional stimulants, but I don't know of specific testing for that. So James Alexander, how can Intuniv be titrated to make sure you're seeing the full effect of each dose change? Should it be a month between dose changes or even more? So Intuniv, or guanfacine, and I do have a video on that, is a alpha-2 agonist, so it works on a subset of the norepinephrine system. And it is, unlike what I was saying before, where I believe Strattera, if it works, Wellbutrin, if it works, if you're at an effective dose, will work robustly and significantly the first day. Guanfacine seems to work slowly, and at least part of what it seems to be doing is modifying via those alpha-2 receptors how glutamate cells are responding to glutamate input in the prefrontal cortex, including growing new synaptic connections and altering wiring. And those processes do seem to take days to weeks to develop and be robust. So my stance when I'm clinically working with patients would be to give it each dose a month before going up. Most of the time, so the doses of Intuniv that are usually used are in the 1 to 4 milligram range for children or adults. That's usually the range most of the individuals that I work with who get a response are going to get a response. And part of it can be difficult to sort out because it's a slower, gradual improvement, and they're asking people to recall how they were functioning or not functioning a month ago compared to how they're functioning now. Usually, if it's a robust or substantial enough effect, they detect it themselves, or are confident that there's an improvement. But they are trickier drugs to dose because of the slowness of the impact. I've had a few individuals who came to me on 6 or insisted we try 6. I'd say in my experience, it's been 6 milligrams. It's been a pretty limited number. The commonest side effect with Intuniv guanfacine is some amount of sedation. And so there are, before Intuniv was approved, there were as many studies looking at immediate release guanfacine as there were extended release. The extended release formulation was intended to make it less sedating. Whether that's the case or not, my clinical experience is use the immediate release once a day in the evening, and if there's any sedative effect, it tends to be helpful for someone falling asleep and not there in the next day in the morning. And given that it's a gradual indirect effect, we probably don't need to be shouting at the prefrontal cortex with the same intensity throughout the 24-hour cycle. We just need a robust enough signal, enough hours in the day. So hopefully that's enough general information to take back and use with your provider. Again, those are not specific medication recommendations for any individual because individuals vary. So, hello to Wayum Moon Ching. Hi. So Dennis asked, at any point in my training, was I required to take a course in intermediate calculus, double integrals, partial derivatives? So I guess this may be personal history day. That's fine with me if that's what's keeping people interested. So I went to a very good public high school in the suburbs of Cleveland, Shaker Heights High School. I scored really well on national tests for both math and English, and we did have not just calculus, or pre-calculus. We had calculus in high school. I got the top scores on the AP calculus tests, and then as an undergraduate, I actually finished an undergraduate degree in 3 years, and I took the chemistry and physics and math courses for those majors rather than the, as I said, watered down version for biologists or pre-med. So I didn't take traditional pre-med courses. So yes, I did take calculus and did well in it. I don't know that I remember much of it or use much of it, but I think it was probably good training for my brain, even if I'm not specifically using those techniques.
So Lai Yuming Ching says, sorry if I'm asks, do you think inpatient treatment facilities undertreat ADHD due to manic addiction tendencies? I would say absolutely. I'd say the San Francisco, the Bay Area, I think is a highly educated urban population, highly sophisticated, and yet I've seen abysmal inpatient care for many patients with ADHD. So I think the big issue is ADHD tends to be ignored or not understood by, in general, this is a gross sweeping overgeneralization, by inpatient psychiatrists. So one of the trends that was already starting in my day in training 30 plus years ago, but which has greatly accelerated, and not just in psychiatry, throughout medicine. We have hospitalists who treat the people when they're in the hospital, and then outpatient doctors, and there's increasingly little overlap information. So something that's appalling to me is I've had patients admitted for suicidal ideation or maybe manic, some mental health crises, not very often, a few a year though. And at least 90% of the time, the hospital does not contact me to ask what are this person's diagnoses, why are they on the medication, what's going on. And equally bad, the numbers aren't much better that when the patient's discharged, no reaching out or connection. To me, that's abysmal care. A tiny point of, maybe in this day and age, and when I was in training, the medicine was fairly paternalistic. The clinicians know best, and we can't trust patients to know or understand the information about their own care. This is general medicine as well as psychiatry. So maybe there's an element of we trust patients more to understand what's going on and to convey that information. So maybe a tiny silver lining is that some of this is due to less paternalism. But anyway, jumping back to the question, I have seen patients who were hospitalized when they were told they were having a panic attack because their mind was racing, and were treated for a panic attack or were sedated to the point that they finally shut their brain down. And it was actually ADD or maybe ADHD exacerbated by tension. And I would say the differentiating factor was the person wasn't feeling or describing anxiety. They were describing racing thoughts and maybe worry then that they weren't sleeping, but they weren't predominantly anxious about anything. I've seen people being told that they had manic depression when every day for at least 6 or 7 years that I had seen this particular individual I'm thinking of, they had always talked a mile a minute. They had always jumped from topic to topic. They were extremely disruptive in a medication group that I had. Not intentionally disruptive, but just interrupting others, not waiting their turn, cutting people off, blurting things out, oversharing on topics that were not relevant to the group, and doing that in a loud and fast voice constantly. The individual I'm talking about, and I mentioned them in my book because it's really important, that individual and I had no longer been treating them, but they had moved to a different state. They had moved back locally. They were in a crisis because they were homeless and jobless and sought psychiatric hospitalization. And they called me from the hospital because they were saying they're telling me I'm manic because I'm showing my usual daily ADHD behavior. And I even talked to the doctors and gave them the history, and they insisted that this individual was manic. And again, there were no other specific signs of mania. They kept treating her with sedating drugs until finally she, after several days, was slowed down. And this patient, a day after getting discharged from the hospital, feeling profoundly unhelped, jumped off the Golden Gate Bridge. So I've seen ignorance about ADHD kill people. So we hear all this hubbub and to-do about how ADHD is being overdiagnosed, how stimulants are horrible and addictive and make people psychotic or kill people. They can do those things, but those are rare. I see far more serious problems from not diagnosing or recognizing ADHD when it is there. And I am aware that anecdotal information will not settle the question as to whether overdiagnosis or underdiagnosis are a bigger problem. So, Simon Bisharat, hello again. Have you tried pregabalin or Lyrica for anxiety? Is it addictive like benzos? So Lyrica is approved for seizure disorders. I think it's also approved now for chronic fatigue or chronic pain syndrome. So it's helpful for chronic pain. Both gabapentin, which brand name Neurontin, and pregabalin have been used off-label for anxiety. The formal tests studies that I've been aware of have suggested rates of efficacy not much better than the placebo or not distinguishable from placebo. That doesn't mean that these drugs may not work for some individuals for anxiety, but it's not a drug that I would use often. And I think much of its effects are that people believe it's going to work for them. Its tolerance and addictivity, so it is working at least some of its action on the GABA systems, like the GABA A binding site that benzodiazepines work on, but it's not working in the same way, or I don't think even on the exact same areas on the subunit. So the clinical, and I believe all the animal research suggests it is not as prone to addiction or tolerance. So if you're getting some effect, you tend to continue to get some effect, particularly for seizures and for pain control. Gabapentin itself is one of the drugs used in psychiatry that has one of the broadest ranges of efficacy. So doses anywhere from 100 to 3,600 milligrams, at least in some people, are tolerable and useful. So Josh Rothberger is saying, I seem to need higher methylphenidate doses versus Vyvanse for ADHD, but get more mood side effects with methylphenidate, maybe because amphetamine has a stronger effect on dopamine in proportion to noradrenaline. So when they're saying higher doses, a few things to remember. On a milligram per milligram basis, methylphenidate Ritalin products are about excuse me, half as strong as amphetamine-based products. That's a general ballpark figure. Different individual results will vary, not vary. That's so if you're doing well on 5 milligrams of Adderall, you might need 10 milligrams of Ritalin. The other thing to remember for Vyvanse is that only about a third, 30%, low 30% of Vyvanse is the active dextroamphetamine. The rest is inactive lysine. So in a 70 milligram dose of Vyvanse, you're only getting about 20 milligrams of dextroamphetamine. So whether mood effects are greater with amphetamine products or whether it has to do with how quickly it's going in. So again, Vyvanse has a very slow entry to the body because of that cleavage of the lysine from the dextroamphetamine is needed, and that at least some aspect of the effects of stimulants is not just how much is sitting at those dopamine or norepinephrine receptors, but how quickly that is changing. So a drug that goes in more quickly may well have more mood beneficial effects, or you might notice it more dramatically. And yes, there may be relative differences between norepinephrine and dopamine, but again, the bigger difference between methylphenidate and amphetamine products is that the amphetamines are much more extensively causing a bigger release. So both drugs are good at dopamine and norepinephrine reuptake blockade. So the dopamine and norepinephrine that's already released can sit postsynaptically longer and act longer and stronger, therefore. But the amphetamine is releasing additional, it's causing vesicular greater release. So there is a bigger surge there. So Luder McGavin is chiming in that they've had bad side effects from Wellbutrin, and Vyvanse seems to do the trick. So I'm glad you found that works. And again, it highlights that we can give general predictions. We can determine whether something has no marketed effect in the general population compared to another drug, but whether that will work for a given individual, so far we have very limited tests or ways to determine what's going to work. So do methylphenidate or amphetamine affect dopamine synthesis? So their strongest effects are on blocking the transporter, blocking the reuptake molecule, and again with amphetamine products causing excess vesicular release. Now, all of our systems in the brain have feedback mechanisms, so having released more or depleted the cell more each time you're releasing some is going to have some feedback mechanisms. What I'm not recalling off the top of my head is whether either of these types of drugs have direct effects on any of the enzymes used to make dopamine. And off the top of my head, I'll just say I can't recall, so I don't have a good answer. I'm going to write that one down. And again, the thought is whether or not it does, that the biggest acute effects certainly are from reuptake blockade and extravesicular release. So Max asks, is there a difference between emotions and mood? Does elation imply happiness, or can it mean feeling energetic, motivated? And does depression imply sadness, or can it mean lack of energy, motivation? So one of the, I'll share more of my personal training. So one of my most wonderful opportunities is during psychiatry residency training, I did a little bit of independent research study in the lab of Paul Ekman. So Paul Ekman is a psychologist who is most importantly associated with studying movements of facial expression and categorizing those and defining the facial expressions for each of the basic emotions. And he had done cross-cultural work previous to that, showing that even in humans that were never previously exposed to a westernized culture, there were similar emotions in terms of similar triggers that elicited them. And that doesn't mean saying exact environmental situations, but fear is triggered by something that seems immediately dangerous to your life or well-being. Now, that might be a car in Western society. It might be a jaguar in the underbrush in the Amazon jungle. So basic emotions had the same triggers. They had the same facial expression. They had some similar physiologic profile, and they resulted in same action tendencies. So blood flow to bigger muscles. If you're angry, gets you ready to fight, right? There are some who object to the concept of basic emotions, but they have not eradicated some basic findings. So emotions in the study of them, emotions are used to refer to short-term, and short-term means triggered within fractions of a second, lasting maybe seconds in terms of release of chemicals in the body but if an emotion is lasting for more than a few seconds, it's almost certainly because it's being re-triggered or reinitiated. So the example I bring up is if you're in a room and someone throws an object at your face, you might have a flash of fear. If it bounces off your head harmlessly because it's a foam Nerf ball, your fear usually is extinguished right away. You might get angry, you might laugh, you might get sad that they decided to pick on you, but the fear goes away. On the other hand, if the ball even misses your head, but you see that it's a rock or a serious element and that other people in the room have similar objects that are ready to hit your head, you continue to feel fear, but you're continuing to feel fear because it's being re-triggered over and over again. So the psychologists who study this, emotions are short-term, specifically triggered by a certain situation. Mood is considered to be a much more pervasive, long-term, general, emotionally tinged state. And it's not just positive mood or negative mood, but it can have, so it's not just valenced in terms of positive or negative, but you can be in a sad mood, you can be in an angry mood, you can be in a fearful mood, but it implies pervasiveness over time, usually not hours, but days, weeks, or longer. So then the second parts of the question are, we have lots of words and lots of different languages, and many times psychologists or researchers try to use the words more precisely than the general population. So we have clusters of words to represent anger. Anger, irritation, peeved, pissed off, are all aspects of anger. Usually I think the dictionary definition would say elation usually implies some positive, joyful, so happiness is joy, is a sense of achieving some goal, or so if it's purely energetic, just feeling revved up and activated, I would say, again, not our colloquial ears, elation would be in the happy family or happy joy family, emotion family, a word family, and that it shouldn't be used in a research sense for just being energetic or engaged or motivated. Depression is even weirder because we use it not just to be a mood, but to be a diagnostic condition. And the diagnosis of depression requires a prevailing mood state, but the state can be one of sadness, or it can be one of numbness, or it can be one of irritability. Often all three are there. Usually sadness predominates, but not always. So hopefully I answered that question. So Borislav Litvinov is just wishing me a great day, and I appreciate that. Let other people know about this. I think it's a good resource. People keep telling me it's being underutilized. I don't know. We're working on improving that, but sharing it word of mouth, I think, is one good way. So Suleiman is, I think, sharing their experience that pregabalin is the only drug that helps for stimulant-induced anxiety. Again, and I've talked about this before, there's actually fairly, both research and lots of clinical experience that guanfacine is helpful for many individuals with stimulant-induced anxiety, agitation. And again, my usual approach would be if your dose of stimulant is causing anxiety, that's strongly suggestive to me that maybe your dose is too high and backing off should help without inducing anxiety. The other thing to remember there is that there's clearly an interaction between the drugs you put in your body and your own emotional state. So if there's something that's going on that's making you anxious, making you worried, already is helping release in your body and brain a surplus of norepinephrine, then adding on your daily boost of norepinephrine, dopamine from your stimulant is going to have a bigger effect and may tip you from the ideal range into an anxiety range. Foshanda Jackson asks, do I believe in mushroom microdosing? So I would say that's a good wording of the question, because right now we are at the state of belief or not belief. My understanding, and I did check into this recently when I updated the psilocybin talk, that there's only been one published study on microdosing, and it didn't reveal any benefits beyond the placebo group. So one thing, microdosing is a very vague term. Usually it's generically meant to mean taking doses of mushroom or other hallucinogens that are not rendering a hallucinogenic experience. The hope or claim is that smaller, maybe more regular, maybe more chronic doses can do some of the same benefits. I'd say that the evidence is, I'd say, fairly robust now that standard dosing of psilocybin can help many people with depression, anxiety, substance abuse disorders, PTSD, and often just a single dose or two. The big caveat of that research is that it's a highly selective population that's been looked at, highly motivated, high expectation that their treatment will work, and high ability to tell when they're getting the treatment and not getting a placebo. So again, it's less clear how generalizable, but at least for some people, these clearly are highly effective. So again, a single study not finding an effect doesn't tell us maybe they weren't using doses that were high enough. Maybe they didn't study long enough. Maybe the population being examined weren't really representative. So it's a single study doesn't disprove it. The other big issue with dosing is figuring out what your dose really is. So one is within the mushroom, your dose of psilocybin is not evenly distributed. So equal-sized pieces from the same mushroom may not give you the same dose. And from mushroom to mushroom, different assay labs have found as much as a 200-fold difference in the concentration of psilocybin. Presumably, some of it's due to the environment the mushroom was living in, proximity to other mushrooms, other aspects of the environment, maybe the genetics of that strain of mushroom. But that makes it, if you're getting a mushroom-based product, again, for years, Sandoz Pharmaceuticals made commercially available psilocin, what psilocybin is broken down into in the body, the active form of it. And in many of the studies that are being used, it is a synthetic version that is being studied. It should have be the exact same chemical as present in the mushroom. Maybe there's additional other chemicals in the mushroom, as I discussed in something like marijuana, where there's multiple clear psychoactive substances. So that's what I'd say. On the other hand, I don't know of damage from mushroom microdosing, so the downside is low, with the possible exception of if you're using it for depression and it's not helping you for depression, but it's keeping you from trying more effective treatments. So that may be a real potential downside for some individuals. So James Alexander is getting back to the guanfacine, and he's asking that in my clinical experience, am I saying that Intuitive, the extended release version, is not better than 10x, the immediate release version, in altering the prefrontal cortex and treating symptoms, and it's just a difference in the sedation period? So, I mean, what I'm saying clinically is that I haven't seen any clear-cut difference. I have not probably had volumes, large enough numbers to make it a good study. So this is, again, my clinical experience. But I've had a number of people on immediate release. I've had a number of people of extended release. I've had more people who said they could sleep well at night and were not sedated in the morning with the immediate release. The immediate release tends to be much more affordable. So Intuitive is still a brand name product and at least an order of magnitude more costly. Whether that's actually altering prefrontal cortexes, that I'd say is my assumption, and that I think that most of our ADHD symptoms are intimately tied to prefrontal cortical functioning. And again, it's Amy Armsten's group at Yale and a few others have done extensive work specifically with guanfacine and prefrontal cortex alteration in circuitry and connectivity. So I think it's an extremely plausible mechanism, but whether I can say that I know that I am altering prefrontal cortex, but no, I don't think there's any difference in the benefits between the two. So Foshanda asks, why are ADHD meds continually going on back order? So I do have a specific talk on this. Much of the media keeps blaming increased rates of ADHD and therefore increased demand. We do know prescriptions writing for ADHD has gone up. ADHD diagnoses have gone up. Those are both true. But when this crisis started, and now it's I'm not even remembering how many years, we're multi-years into it. It started very specifically with Adderall and with the 800-pound gorilla on the block, which is Teva Pharmaceuticals, which provided more than 80% of brand name and generic Adderall on the market during COVID, when workers were laid off and workers then were demanding higher wages. Teva decided not to hire back as many workers, and they knew that, or not to pay them more money, and they knew that that would result in manufacturing shortages. So the crisis started by Teva not holding up its obligation. So the federal government, DEA, for controlled substances sets a market, says how much of this drug can be manufactured and or brought into the country each year. And then it divvies up that pie and assigns to each company their share of the market. And Teva had the lion's share of the market. So they had an obligation to make X amount of Adderall, and they did not live up to that obligation. And when, again, the supplier of the majority of it starts to fail, then that put more pressure on some of the other manufacturers. Some of the others also didn't live up to their expectations. Teva acknowledged at the time it was not supply chain issues. It was not other valid, I would argue, short-term responses to the COVID industrial environment. It was how many employees they had to churn out the stuff. So the other thing that the DEA does is that not only does it regulate the supply, it actually micromanages the distribution. So it allots how much each pharmacy is getting it, and it allots it on its own formula that the pharmacies don't know all the details of, that involves somewhat historical prescribing practices at that pharmacy, how much that pharmacy still reports they have on stock each week or 2 week period. So the pharmacies themselves often do not know when they are going to get more, when we're having shortages. So yes, there has been a demand increase, but a lot of the problems have been at the supply side. There are slightly different issues related to Concerta shortages, and I had a talk on that as well. Gina Pera's blog, and she wrote, I think the blog is called the ADHD Roller Coaster, but her name, Ginapera. You can find her. She originally was a journalist and investigator, and she's written probably more extensively and clearly about the causes for some of these shortages and ongoing problems. So the other thing is, once a given item is in short supply, then that causes spillover effects for other dosages and other medications that people might have used or substituted. I see I'm over an hour now. I'll try to answer the questions that are in, and then I don't have a firm limit, but I don't want to go on too long today. So Wesley DeVries asked, is my new book out already? What I'm finding is that even publishers that say they can do things quickly, I mean, self-publishing things can come out quickly. I am thinking of taking, I wrote 52 essays after my first book came out. I wrote 52 essays on ADHD using Donald Trump as an example of perseveration, using an example of blurting things out, using an example of hyperactivity. So yes, maybe Trump is toxic to people, but the essays are well written, and I'm thinking of putting all those essays out as in a book form, and maybe self-publishing, which can come out relatively quickly. So I am in the works of writing a book on ADHD and it's called ADHD World, how our whole world is getting more ADHD-like. That I'm halfway through the writing. The writing should be done in the next few months, but the book will not be coming out until the second half of next year. And that's a faster turnaround than the really big prominent publishers can offer. Slayman asks, which mood stabilizers can help with ADHD rage outbursts? Can lamotrigine help? I've seen people feel clinically, I'd say yes, it can help. Actually, the right dose of stimulants in rigorously done studies, Russell Barkley's been involved in some of that in the past, can help with anger outbursts or extremes of anger. So stimulants can help modulate, help with emotional regulation. And particularly with anger, there's some research, not necessarily only in the ADHD context, but Depakote, valproic acid, helping stabilize mood. Stargate Works X3D asks, is parallel titration in case of desired Vyvanse for daytime and THC dominant medicinal cabinets for evening use, both long-term, more on-demand, something worth trying to talk about with a doctor? So my general bias is you don't want to be changing two variables at the same time, because then you don't know. So I think what this person's asking is it reasonable to be titrating upwards or downwards on your dose of Vyvanse for daytime ADHD at the same time you're titrating or altering THC or other forms of cannabis for sleep or calming down? Again, my usual approach would be to only change one variable at a time, and once you seem to get the desired, and probably starting with the Vyvanse, just because the results here, it's less maybe crucial than with the antidepressant that works slowly. Either of these drugs, you should be able to pretty quickly tell what a given dose is doing. And yes, we all have day-to-day variation, so one day may not be definitive, but 2, 3, 4 days at a given dose of Vyvanse should give you a pretty good idea of what it's doing for you, unless your life is in unusual circumstances, you're traveling or you're on a vacation from work or something. So I would tend to focus on one and then the other. And yes, there are interactions, so getting better sleep may then mean that you don't need as high a dose of Vyvanse, but manipulating both simultaneously doesn't seem like a good strategy in general to me. Hello, Lewin Katifa. Have you heard of people taking a nap after ADHD medication? So I've talked about this, and I think I've written about it on Medium. I think I talked about it, I don't know if it's in the siesta time, or maybe the Medium article is titled something like, "Who takes a stimulant before bedtime?" So certainly there are some people with ADHD who need to, you can't calm their mind except by taking a small dose of a stimulant, and that helps them fall asleep at bedtime most often. It would probably help with a nap. I also have a number of people who wake up early in the morning, an hour or two before they intend to get up for the day, take their stimulant, can fall back asleep, and then the stimulant starts working. And it's not that the stimulant working wakes them up, it's that once they wake up, then it is more fully in effect. So it means that at least to some extent they were able to sleep while some of it was working in their body. So James Alexander asks, what's my own clinical experience with Qelbree? So part of it is, since moving to Hawaii, I've not taken on new patients. So most of the people I'm working with are fairly stable on their current regimens. And so my direct clinical experience is small, and more of my clinical experience is indirect, and people actually writing in and discussing with me. They started Qelbree with their doctor, and what I can say is sort of like everything else. For some people, it seems to work and work really well. For others, they don't seem to get benefit. I haven't identified a specific population that it seems the best fit or an ideal fit for, or any population where I'd say definitely don't go there. So Tainer asks, any evidence of gabapentin helping cases of comorbid ADHD and anxiety? I do have talks here on ADHD and anxiety. I'd say gabapentin is one of the logical things to try. Again, I would start with adjusting dose of whatever existing medicines, particularly if it's a stimulant or a norepinephrine boosting drug that could be directly worsening anxiety. Again, clearly some individuals with ADHD have and anxiety. When ADHD is adequately treated, anxiety goes away. And guanfacine to me is probably a more desirable choice than actually adding on something that is, gabapentin ultimately is sedating to some extent, and gabapentin is short acting, so it should not have, the sedation should not be pervasive, but there's an antipathy in my field to, although sometimes we do it, and some doctors do a lot of it, to be chasing uppers with downers. That is the person really that regulated? They need to be pushed both directions. So Max is thanking you on great questions today, and I appreciate them. And he reminds you every week, I'll be back at the same place, same time. And so Stargates, yeah, so it's, I think Stargate sort of agreeing that it makes sense to regulate or modify one first and then the other, but he was worried that providers would tell him not to use cannabis and that he should just be tolerating the Vyvanse, and that they might wind up on more Vyvanse than they needed just because they were using cannabis. One thing to remember with cannabis is that cannabis, as opposed to gabapentin, has a very long half-life in the body and presumably is contributing to some amount of sedation, some amount of, so I do have a talk on marijuana and ADHD, and while it helps some people, on the surface, it's a bad match for ADHD because it affects sedation, affects motivation, affects organization of thoughts, potentially, but may help some people. So stay healthy, stay happy. I'll be back next week. And that's all for today.